Chapter 20, Assessment and Management of Visual Problems.
Vision is the dominant sense for most people with sight. The organ of sight is the eye. Think of it as a slightly irregular, hollow sphere that takes in light and translates it into images. If we enlarge the eye and look inside it, we can discover how that's done. Inside the eye are various structures working together to create an image the brain can understand. Among these are the cornea, a clear dome-like structure covering the iris or colored part of the eye, the lens directly below it, and the retina, which lines the back of the eye. The retina consists of thin layers of light-sensitive tissue. This candle can help us understand how the eye captures images and then sends them to the brain. First, the candlelight passes through the cornea. As it does, it's bent or refracted onto the lens. As the light passes through the lens, it's bent a second time. Finally, it arrives at the retina, where an image is formed. This double bending, though, has reversed the image and turned it upside down. If that was the end of the story, the world would always appear upside down. Fortunately, the image is turned right side up in the brain. Before that can happen, the image needs to travel as impulses along the optic nerve and enter the brain's occipital lobe. When the image forms there, it regains its proper perspective. Now let's consider two common conditions that cause blurry vision. The eye's shape is important for keeping things in focus. With normal vision, light focuses precisely on the retina at a location called the focal point. But what happens if the eye is longer than normal? The longer the eye, the more distance there is between the lens and retina. But the cornea and lens still bend light the same way. That means the focal point will be somewhere in front of the retina rather than on it. This makes it difficult to see things that are far away. A person with a long eye is said to be nearsighted. Glasses with concave lenses can correct nearsightedness. The lens widens the plane of light coming through the cornea. That pushes the focal point back onto the retina. Farsightedness is just the opposite. The eye's length is too short. When that happens, the focal point is behind the retina, so it's difficult to see things that are up close. Glasses with convex lenses narrow the plane of light. Narrowing the light passing through the cornea moves the focal point back onto the retina and can correct farsightedness.
Okay, so I skipped through all the images prior to this slide. You can go back to reference those if you need to. So here we are at the visual pathway. So let's take a look at what happens when we look at an object. So here we have our eyes. The light passes through our eye, through our cornea, through our aqueous humor, through our lens, through our vitreous humor, to the retina, to the optic nerve, to the optic chiasm, where it crosses, and then it goes up into our brain where it processes the images that we see and interprets them and tells us what we're looking at. So when you look at this visual pathway, anything can happen between our eyeball and our brain. So that's where the problems lie. That's what we're going to talk about. Okay, so we're going to start off with gerontologic considerations. So as we age, everything in our body is going to change. Some things are going to be benign. It's not really going to affect us, but some things can affect us. So here are some examples of that. So this table is from your textbook, so you can refer to it on your own, just kind of read through it. These are some common changes that happen to our eyes as we get older. So here is the hooded eye. That might not be as, it may not affect a person's daily life unless that hood becomes very, very low and it can block vision. Otherwise, we just leave it alone. So this ectropion here can also be entropion. It's where the lid kind of curves out. So this is ectropion, and then entropion would be if it curves in. Again, this doesn't have to be corrected unless it's causing a problem for the patient. Okay, then we have some fat deposits here. You can see these little yellow pockets here. Again, those don't have to be removed. It's could be cosmetic, or if they get really big and they're causing a problem. Okay, so just read through those. Okay, this is a continuation. Very common, arcus senilis. This is a benign problem, but it's very common, especially when you're standing in the sunlight. You see like this gray halo around the eye. Okay, moving on. So just read through these. Really important to remember here that photophobia is not a normally occurring change with aging. So if you have a patient that reports photosensitivity, sensitivity to light, they need to definitely be tested and examined further, because that's not a normal change with aging. Okay, so diagnostics. So there are a lot of different types of visual testing. The one that I want you to focus on is the visual acuity test, because that is like the baseline. If anybody complains of eye pain or some type of vision issue, blurriness, anything like that, the first thing that you're going to do is a visual acuity test using a Snellen chart, which we will see on the next slide. So these are some other examples of different kinds of studies that can be done. Please review this table here, table 20.6 on page 358, so you can just read about each one. So this slide describes what the visual acuity test entails. So all of us have had this at some point in our lives, I'm sure. It's very common, especially for young children. This should be part of their health checkup for their doctor's appointments. And this is also done in schools. So at certain grade levels, this will be done, and this is how a lot of eye problems are found when the children are at a young age in school. All right, so how do we do this? Well, the person has to sit 20 feet away from the Snellen chart. Okay, the Snellen chart is seen here. It's those letters that gradually get smaller and smaller. So 20 feet from that chart, if the person has prescription glasses or wear contacts, they should keep them on. And then we document that as corrective vision. So first we start with one eye covered, and then they read the smallest line they can see, and then they cover the other eye, do the same thing, and then they uncover both eyes and then do it again. So normal is going to be 20 out of 20. So the first number, 20, stands for 20 feet away from the Snellen chart. The second number means that at 20 feet, you can see what's expected at 20 feet. So if you have vision that's 20/30, that means what you see at 20 feet, somebody else can see at 30 feet. Okay, so that means the higher that second number, the poorer and poorer vision you have. So if you have 20/50 feet, that means you're still standing 20 feet away from that Snellen chart, but somebody standing 50 feet away can see what you're seeing at 50 feet, and you have to be 20 feet away. Okay, so just remember that second number. As it gets higher, the worse the vision is. And then here you can see legal blindness is considered the best corrected vision of 20/200 or less. So that means the best corrected vision. So the person can be wearing glasses or contacts and they still have 20/200 or less, meaning it's really bad. Okay. So I'm
The
going
human
to
eye is
skip this
able to see
video.
objects with the help of eye lens and retina. The eye lens is held by ciliary muscles. Normal human eye can see nearby and far objects clearly. Power of accommodation. The ability of the eye lens to increase or decrease its focal length to some extent by ciliary muscles is called power of accommodation. Working of eye lens. The eye lens is made of a fibrous jelly-like material and hence it is flexible. To see far-off objects clearly, the ciliary muscles relax to decrease curvature of the lens and it becomes thin and its focal length increases. Thus, image of far-off objects is made on retina and the eye is able to see distant objects. To see nearby objects, the ciliary muscles contract to increase curvature of the lens and it becomes thick. Thus, focal length of the eye decreases and it is able to see nearby objects distinctly, like reading. Limitation of power of accommodation. The focal length of the eye cannot be decreased below a specific limit. The eye cannot see objects clearly below 25 centimeter. So near point of distinct vision for normal human eye is 25 centimeter. However, there is no such limit for distant objects. Therefore, far point of normal human eye is infinity.
So we're going to talk about the first problem, refractive errors. So what is refraction? If you watch the video, hopefully you have a better understanding of what it is. So it's the eye's ability to bend light rays so that they fall on the retina. Okay, so we're looking here at this picture. Actually, this is a really good example of the different types of refractive errors. So this first one here, you can see how the light goes in how it should be, and it lands back here on the retina where it should be. So here it's not landing right. Here it's still off course, and then here it's all spread out. So something is causing the light not to land where it should on the retina so that our brain can interpret it correctly. So the cause of this is a couple problems. You might have been born with your cornea curved abnormally, or it can be the actual focusing power of the lens itself or the length of the eye. So these things were typically just born like this, and it can also be a result of aging. So this is going to be blurry vision, really simple, and over time it can cause eye discomfort, pain, eye strain, and headaches. That's why kids, when they complain, oh, I have a headache in class, I can't see the board, so it's straining on their eyes so much that it causes headaches, so we should have their eyes checked, their vision checked. And then these terms here, be familiar with those. So myopia is nearsightedness. That's the inability to accommodate objects at a distance. And this is the most common refractive error, so myopia. Then we have hypermyopia, which is farsightedness, which is the opposite. So it's the inability to accommodate near objects. And then we have presbyopia. Whenever you see this prefix, it's referring to age-related changes. Okay, so this is presbyopia, the loss of accommodation associated with age, and this is due to the lens becoming larger, firmer, less elastic. Okay, so remember, with age, the lens in the eye becomes firmer, less elastic, and it becomes a little larger. So you have presbyopia, which is the inability to focus on near objects. Okay, astigmatism is when the cornea is curved irregularly or uneven. And then we have aphakia. That is the absence of the actual lens itself. So that can be due to some kind of congenital anomaly. Maybe they weren't born with a lens, or if they have to remove the lens during like cataract surgery, something like that. So to correct refractive errors is pretty simple. We have glasses or contact lenses. So glasses can help with myopia and hyperopia. So that would mean kind of like reading glasses. And then if you have both nearsightedness and farsightedness, you can wear like trifocal, bifocal, where the lenses are placed on the glass here. specific to where you would see. So this one would be near, like you're reading, and then this one would be distance, and so on. Contact lenses can be really effective. They're not for everybody. So for contact users, you want to make sure that they follow the manufacturer's instructions on hygiene and the lifespan of the actual lens. So you can get some that you have to change daily, or some are a week at a time, and so on. But you should remove them regardless of the length of how long you keep them. You should remove them every day. Soak them in whatever the recommended solution is to keep them free of bacteria. So these patients are going to be high risk for infection, eye infection. And the complication that we're trying to avoid is keratitis, which is infection of the cornea. The reason for that is because keratitis can lead to blindness. So we want to avoid that. Okay, so we want to educate them on proper care, proper eye hygiene, and not to wear those contacts when they have an infection or when the eye is inflamed. Okay, some patients would meet the criteria for laser surgery. Very common is LASIK. That's what this little video is here, so I'm going to skip this. Another
During
option for
laser-assisted
patients is
refractive lens exchange,
intraocular
your
lens
ophthalmologist will use
So
a
this
laser
little video,
instrument
as we
guided
watched
by
in
a
class,
computer.
the lens is
The
actually
laser is
removed
used
and
to make
replaced
small
with
openings
an
in the side
implant
of your
or
cornea.
artificial lens.
Then your eye surgeon will insert a pen-shaped instrument through the opening to reach the lens. This instrument uses a special type of energy to break up the center of the lens. Then it will carefully suction out the broken lens pieces. Your surgeon will then insert an artificial lens called an intraocular lens, or IOL. This IOL will stay in your eye permanently. The new lens lets light pass through and focus properly on the retina, bringing back clear vision.
Moving on to visual impairment. So what is considered visual impairment? So this is vision that cannot be fully corrected. So if you wear glasses, that does not mean you're visually impaired. If the glasses or the contact lenses make you see 20/20, then you're good. But if you have the strongest strength glasses or the strongest strength contact lenses and you still see very blurry, you can't see, then you'd be considered visually impaired. Okay, so it's vision that even after we correct it to the best of our ability, you still cannot see. So the terms low vision would mean you still have some good usable vision. Severe vision impairment, some of the criteria would be unable to read newsprint, and you may or may not be considered legally blind, again, and that's based on the visual acuity test. And we mentioned this earlier, legal blindness is 20/200 or less. So most blindness in this country results from cataracts, glaucoma, age-related macular degeneration, and diabetic retinopathy, all things that we are going to talk about later in this chapter. So nursing management for visual impairment. So these are patients who can either see a little bit or not at all. So how do we treat them? So in the acute care setting, when you're in the hospital with these patients, communication is going to be priority, because if they can't see you, you have to make yourself known. You need to introduce yourself. You have to comfort them, make them, trust you. What are you doing in the room? Who are you with? You want to make eye contact, you want to follow the patient's cues, and you definitely want to say goodbye when you're leaving the room, because if you don't and they don't see you, they can still be talking to you and you're not there. Continuing on with nursing management in the acute care setting, when you want to help this patient ambulate or maybe you're transferring to the chair, standing up, going to the bathroom, you want to use a sight guide technique. So this means that you're going to walk slightly in front, side by side, and then you're going to offer your elbow to hold. So like this picture here. Okay, as you walk, you want to describe the environment. Okay, you know, there's a stair here, there's a step, there's a table, we're going to turn this way, etc. And then if they're going to sit down, you want to place their hand on the seat of the chair so they can feel it. On the outpatient basis, we want to make sure that they're going to be safe and as independent as realistically possible. So when somebody has visual impairment, it can really affect their self-esteem. They can be depressed, they may not want to leave, they may feel insecure, especially when they don't have a good support system at home. It can be very scary. And this goes for people of all ages, kids to the elderly. There is a lot of state and federal assistance available, so that's something that you want to educate and provide resources for them. And there's also lots of, especially nowadays, Braille, audiobooks, cane, they can qualify for a guide dog, all that kind of stuff. So then we're moving on to optical devices for vision enhancement. So you want to make sure that these patients take advantage of all the technologies that are out these days, and all of the stuff is very accessible. So you can see in the pictures, there's magnification for reading. You can use a device, old school magnifying glass. Here, computer can help you do it. So there's all kinds of options for these patients. Non-optical methods, meaning none of those things that we just saw on the previous slide, to help with magnification. So like this picture, you know, growing up, your mom said don't sit close to the TV. Well, here these patients can sit close to the TV to see better, or they hold things closer to their face. Contrast enhancement techniques. So if you change the contrast sometimes to black and white, it can make it easier for your eyes to discern shapes and colors. So that might be an option. Increased lighting, natural lighting is usually best, or incorporating large type to see better. Okay, patients who are visually impaired, especially completely blind, can experience sleep-wake disorder. Because our circadian rhythm relies heavily on sunlight, these patients, their brain just doesn't know when it's day or night, so they end up flipping, where they're awake at night and then they get sleepy during the day. So they'll have insomnia, excessive sleepiness, and if they're still working, you know, this can cause a problem. So we want to treat it pretty much as minimally as we can. So melatonin or melatonin receptor agonist, depending on what their problem is, can be effective for them. All right, so nursing management promoting health, so eye health, so responsible eye care. This should be for everybody, so appropriate hand hygiene, because we don't want to bring bacteria and pathogens and other microbes into our eyes. Appropriate healthcare, so go and get your vision test, your visual acuity test as scheduled. Sunglasses and proper nutrition. So we're going to talk about nutrition a little bit later. Sunglasses to protect your eyes from the sun. If you're doing some kind of handiwork in the garage using big machinery or things that have the potential to fly in your face, especially if it's part of your job, then you want to make sure you use eye protection so you don't cause any trauma to your eyes. And now we're back to gerontologic considerations. So as we age, we are at a high risk for vision loss. And as we age, it is likely that we're going to have other ailments, like maybe issues with mobility. You have to use a walker or a cane, or maybe you're hard of hearing. So having visual impairment on top of that can really be detrimental to someone's independence, their psychological state. You know, they might feel like they don't want to leave home. They'll feel isolated. Finances can also influence their ability to get all of those devices and certain resources. As we get older, we are already at an increased fall risk. So if you're visually impaired, of course, that's going to make it even a greater risk. We talked about independence, their self-image, dexterity. So these patients might already have like arthritis. They may not be able to give themselves the eye drops for their eye problem. So all of these things we need to consider when we're dealing with the geriatric community. Okay, moving on to eye trauma. So the most common cause of eye trauma in this country are falls and fights, and this is very preventable. So again, we want to educate. People at home doing everyday things can cause eye trauma: cleaning, gardening, using any kind of tool, sharp objects, playing sports. If you have an occupation where you're, again, I mentioned earlier, potential of things flying in your face, you want to make sure you protect your eyes. For chemical eye trauma, you see in this first picture here, this is called a Morgan lens. We use it for irrigation. The irrigation solution is just there to flush out any debris or liquid or anything that's in the eye. The emergency management table is 20.7. We're going to see that in a second. And the education is protect your eyes. There's lots of different things you can buy for your face shield, goggles, etc. Okay, so this is the table from your textbook, Emergency Management Eye Injury. You should definitely just kind of read through this. It's pretty basic. So there's chemical burn is actually the most scary, the most serious. It can be the most serious right away, because if you get a chemical burn, it's going to start just destroying the eye. So for those, you really want to make sure, of course, we're going to assess airway. And the reason for that is because our eyes are on our face and our mouth and our nose are on our face. So anytime you have any kind of injury on the head, airway is always going to be priority. Okay, so you checked airway, you're going to look for other injuries, make sure they're not bleeding out from something else. Assess for chemical exposure. Again, we talked about burns. Chemical can be, it can melt. It causes that protein lysis. It causes melting. So it can just melt away the eyeballs really quickly. So if you have some type of chemical burn, you really want to flush out your eyes as soon as possible. If you have sterile saline, of course you want to use something like that. But if not, you get the water hose and you do it just to get all of that chemical out. Okay, and then just continue reading on that chart. All right, so now we're going to start with our disorders. So the first is extraocular disorders. Extraocular is referring to the structures you can see on the outside of the eye just by looking at someone. So inflammation and infection, so just like anything else, we can have these things happen to our eye. We already know what inflammation is. We're going to have the pain, the redness, the edema. An infection is going to have some kind of infectious agent. Right now we're going to talk about viruses, fungi, and bacteria. All right, so starting with external hordeum or stye. So this is considered an infection. So this is when you have actual bacteria in the stye. This can be self-limiting. So if you apply warm compresses, it usually will go away on its own. Antibiotics can be prescribed, but usually they'll just go away on their own. And what happens is these little meibomian glands here get clogged, and that's what causes the inflammation and subsequent infection. This calizion here is actually just like a stye, but it's non-infectious, so there's no infection, and it is from a meibomian gland obstruction. And this one can actually cause this little pocket here to get pretty big. So we do the same thing, warm compresses. It needs to drain, and you might they might be prescribed some kind of topical corticosteroid if that inflammation doesn't go away on its own. This one might have to be drained by the provider, lanced and drained. Okay, so remember the stye, the external hordeum, is an infection from bacteria. Calizion is non-infectious. Okay, no bacteria. Then we have blepharitis. So this is eyelid inflammation. It can be the top and bottom at the same time. Usually it's top and bottom, both eyes. So this one is going to cause crusting, like you see in this picture, lots of crusting. So you're going to want to educate the patient to keep it clean. They can use a gentle cleanser for that, wipe away. And you also want to educate on good hygiene. So they should throw away those tissues and the cloth. They shouldn't share towels with somebody else in the house. They want to wash their hands, that kind of thing. And then this patient can also have antibiotic ointment for that. Okay, now we're going to move on to the conjunctiva. All right, so we're all familiar with the word conjunctivitis. That can mean inflammation or infection. So the first one is the one we always hear about, pink eye. So this is a bacterial infection. Pink eye is bacterial, and Staphylococcus aureus is the culprit. So this is common in school-age kids, elementary school. So this is usually one eye. It usually starts in one eye, and then it jumps over to the other eye just from poor hygiene. You touch one eye, you touch the other one. And it's sometimes hard to prevent in young kids because they're too young to understand. So classic symptom of this would be patients will complain that their eyes are glued shut in the morning, or one eye is glued shut from all of that purulent drainage coming out. So that is bacterial pink eye. Again, you want to encourage good eye hygiene, good hand hygiene. So with this one, it's usually self-limiting. You don't need antibiotics, but if you happen to go to the doctor, they will prescribe antibiotics for the eyes, like eye drops, which will just clear up the infection quicker. But for that one, it's usually self-limiting. It'll go away on its own. Okay, we're not going to focus too much on the viral and the chlamydia one. Just know that these things can happen. You can read more about it in your book. Remember, for bacterial, we use antibiotics. For viral, we usually just treat the symptoms. Sometimes antivirals are appropriate, but usually we just treat the symptoms of viruses, and that goes for not just the eyes, but in our body. And then the chlamydia one, obviously that's an STI, sexually transmitted infection. So you can imagine how it got in the eyeball. So that can be serious. That can cause blindness. That is not that common here. It's mostly in other countries. We have something else. So again, we're going to talk more about that one in our STI chapter. And then the allergic one. So we talked about this, allergic reactions. This usually involves both eyes, and they're watery. Okay, so this little box here is general information for all of these things. These patients will experience discomfort, redness, itching, foreign body sensation. So when they blink, it kind of feels like they have sand in their eye. Photophobia, there's that word again, light sensitivity, so that's not normal. They can have drainage, edema, and tearing. Treatments, again, could be palliative, mean just comfort, like for the virus, or topical or systemic antibiotics, corticosteroids for inflammation if it's really bad and it's appropriate, and antihistamines. For patient education, I'll say it again, good hand hygiene, good eye hygiene. You don't want to cross-contaminate and give it to other members in the household. If it's allergic, then you want to avoid whatever allergens are exacerbating your eyes. And then, of course, people who wear contact lenses should not wear them if they have any of these conditions. Okay, so you don't want to wear them when you have infection. Okay, so another view we're going to talk about keratitis. So you can see our cornea. This is what we're talking about. Okay, so we mentioned earlier that keratitis can lead to blindness, so it's important that we prevent this. So keratitis can start as inflammation and lead to infection. And again, we're talking about the cornea. So this can be from bacteria, virus, or fungus, parasite. It can all cause this inflammation of the cornea. So people who are at higher risk for a bacterial infection would be if they've already had some type of damage on the epithelial layer of the cornea. If you wear contact lenses, it also puts you at higher risk because bacteria can live on those lenses. Okay, nutritional deficiencies, if you're already immunocompromised, and then if you're using contaminated products such as cosmetics, can also, anything you put near your eye. As far as viral infections, herpes simplex virus and varicella zoster virus, we'll learn a little bit more about those later. Again, we usually either treat this by the symptoms or with antivirals if appropriate. So with this one, antivirals are corneal debridement. With this one, pain meds, corticosteroids, antivirals, mydriatics, and antibiotics. Okay, and other, it can be fungal or parasitic. It can be related to inadequate closure. So if your eyes, our eyelids protect our eyes. So if you have some issue with that, maybe you had a stroke and your eye doesn't close all the way, you can be more prone to these kind of pathogens. And then we do want to have aggressive treatment to avoid loss of vision. This usually includes like drops every hour, sometimes antibiotic drops every hour, just to make sure that that doesn't progress to something not good. Okay, this is what we don't want it to progress to. So infection of the cornea can result in tissue loss of the actual cornea, and you can see in that picture. So it can be any of those things, bacteria, viruses, or fungi. The way you're going to know you have this, you're going to have pain, you're going to feel, again, scratchy when you blink, you're going to tear, you can have drainage, you're going to have redness, and that photosensitivity. So again, I mentioned to avoid permanent vision loss, you're going to need eye drops around the clock. If you don't get this treated, it can lead to scarring, perforation, and you may need to get a new cornea via transplant. Okay, so again, for infection and inflammation, you want to assess ocular changes, okay, and then you want to also not forget about the psychosocial aspects of impaired vision. We talked about that. We're going to educate, hand hygiene, stay away from things that irritate your eyes, what to report. So all those signs and symptoms of infection, also vision changes. So if all of a sudden they see blurry or they see things floating around, okay. Compresses, warm compresses help drain and increase circulation around the eye. Cool compresses can help with pain. And then of course medication and eye drops, you want to educate them on how to instill eye drops. The tip of the applicator should not touch the eye so it doesn't get contaminated. You want to pull down the lower lid and drop in your drops that way. If you have multiple types of eye drops, there has to be a gap in between. So for testing purposes, you're not going to be tested on 5 minutes, 10-minute gap, 15-minute gap. You just need to remember you can't do it because you need a few minutes at least in between each eye drop so that they can absorb before you place the new one. Okay, moving on to non-infectious disorders. So we have, I'm starting here in the dry eye disorders. So this is a fancy word, Keratoconjunctivitis, that's just dry eye. You can have irritation or you feel like sand in the eye. It's a decrease in the tear film on the eye. So for this, patients can use artificial tears or ointment, cyclosporin, eye emulsion, or Restasis. Or you can have a surgical procedure to close that lacrimal puncta, which is what usually drains the extra tears in our eyes. Okay, moving on here to strabismus. That is another word for double vision. That's when your eyes can't focus at the same time. So one will deviate in, out, up, or down. And then we have words to describe that here. Okay, down here, cornea transplant, aka keratoplasty. It's considered to be safe and fast of the transplant surgeries. And again, this is when you have a lot of scarring in the eye, or you have this keratoconus. Keratoconus is pictured here. It's where, if you can see closely, the cornea is kind of protruding out. So that might also require a cornea transplant. We don't need to know much about this, just know it exists. And it's similar to any transplant where they have to make sure there's a match. Okay. Post-operatively, you want to monitor the eye for infection, and those signs and symptoms are the same signs and symptoms you would have for any other type of post-op procedure. Those 5 inflammatory responses plus infection, so the exudate, increased pain, that kind of stuff. And then we have some more corneal disorders, so corneal scars, and then that keratoconus we just talked about. All right, cataracts. Cataracts is pretty common, so you should be familiar with cataracts. So when you think of cataracts, think of lens, okay, the lens. And the lens should be nice and clear. With this one, it is, the opacity is no longer clear, so that's what's going to give the blurry vision. So risk factors is going to be age. As we age, we're going to be more at risk for getting cataracts. Trauma, if you had something poke in your eye and then, 10 years, 15 years ago, you're going to be more prone to developing cataracts later in life. Family history, it can run in families. And then if you have some kind of systemic disease, especially if it's affecting circulation, such as diabetes. So signs and symptoms is going to be gradual, painless loss of vision. Okay, remember, it's the lens, so it's going to be all the vision. blurry or double vision, and then as this condition advances, the pupil will turn white or gray, as seen in this picture here. So how do we diagnose this? So absent red reflex, this is typically done in children when they're diagnosing other problems. And this is when you kind of shine a light in the eye and you get this red reflection, which is normal. So when you don't get that red reflection, that means there's something blocking that light's ability to bounce back at you normally. So that would warrant further investigation. So just because you don't have that absent red reflex, it doesn't automatically point to cataracts. It's just, one thing to look further into. Okay. Physical exam, you want to get a good health and history to see the risk factors and lifestyle, those type of things. Visual acuity test, again, everybody with an eye problem is going to get a visual acuity test using the Snellen chart. With this one, the ophthalmoscope or slit lamp, where they shine a really bright light into the eye, is what's going to diagnose the cataracts. So you can see here's a picture. This is a normal lens. The light comes through and it's able to go to the back of the retina appropriately. When the lens is clouded like this, the light comes through the lens, but it's diffused. Okay, it's not pinpoint, which is going to mean that we don't see fine details. We're going to see blurry. Okay, so there's two options for this. This is progressive, so if you do nothing, it will become worse. Treatment is either non-surgical, which we consider temporary because, again, it can progressively get worse and you can end up blind eventually. So temporary things that we can do would be glasses, prescription glasses, magnifying glass, that kind of stuff. But again, that's temporary. The treatment of choice would be surgical removal of the lens, and then you get a implant lens. So your role as the RN is going to be focused more on identifying patients that are at risk and being able to recognize a patient who is describing their signs and symptoms so that you should think cataracts. Okay. Also, post-op surgical treatment for this, you should also be familiar with this. So these patients are going to be on eye drops, antibiotics, steroids, and NSAIDs. After procedure, they should wear dark glasses to protect the eye during sleep, like this picture here. Okay. They should avoid activities that raise intraocular pressure. Now, this is true for pretty much every eye procedure. You don't want to have increased intraocular pressure. So you don't want them to bend at the waist, you don't want them to sneeze, cough, blow nose, no heavy lifting, and you don't want them straining with their bowel movements. A lot of patients have improved vision right away, right after surgery, but some don't, and that's okay. It's going to take several weeks for the vision to fully reach the potential. So just reassure your patient. So expected after cataracts is really minimal to no pain at all. So if they complain of a lot of pain, then that's something you want to report to the doctor. And hygiene and eye care, again, washing the hands, keeping an eye out for those signs and symptoms of infection. We want to teach them on eye drop installation. So this is going to be several times a day post-operatively. It might be just in the one eye or it might be in both eyes. So we want to educate them on that, and again, how to administer them correctly with an interval in between if they have multiple different types that they are prescribed. And then we have follow-up with the provider. So these patients need to follow up to make sure that their vision returns and that they don't have any signs and symptoms of infection. Okay, this just shows how someone with cataracts is affected. So you can see the first one's normal, the second one have some color changes, and then the next one's blurry, and then we have some distortion. All right, so now we have retinopathy. So this is microvascular changes to the retina. Okay, it causes blurred vision and progressive loss of vision. And I hope you guys remember this is most common with hypertension or diabetes. So for diabetic retinopathy, there's two types, either non-proliferative or proliferative. The first one is loss of central vision. Okay, so central vision is right in the center. So you kind of develop like this little black spot, black area right in the center of your vision. Then we have proliferative. So this is once it has progressed and you have severe vision loss. So non-proliferative will eventually turn into proliferative. The treatment for this is laser photocoagulation. So if you look in the picture, okay, this is a normal eyeball and this is diabetic retinopathy. So they develop these little hemorrhages in the eye, these little bleeding vessels, and these hard exudates and these microaneurysms. And that is what essentially is causing the issue. So with laser photocoagulation, they can go in with a laser and just zap all of them and kind of stop them in their tracks, and that will usually stop the progression of retinopathy. But of course, you want to make sure that you're treating the diabetes and that their blood sugar is controlled. Then we have hypertensive retinopathy. And the treatment for this one is going to focus on lowering the blood pressure. So hypertension can cause damage to the retina of the eye. Okay, so again, we just want to lower the blood pressure, and that usually, in a way, fixes the retinopathy. Okay, and here's a picture of a healthy retina on the left, and then on the right, you can see all of those little micro hemorrhages and exudates. Okay, moving on to retinal detachment. So this retina here is this pink, that is the retina. It lines the whole inside of our eye. And what happens is we have a tear in the retina for whatever reason we're going to talk about. So the fluid kind of goes through that tear and it starts to separate the retina from the back of the eye. That's not good. Okay, so again, retinal detachment is separation of the retina and underlying epithelium. And then you have that fluid accumulation between those layers. So etiology is going to be breaks, tears, or holes. The tears are more correlated with aging. So again, this is the risk of retinal detachment increases as we age, specifically over the age of 50. If you've had a previous retinal detachment or family history, if you have severe myopia, if you've had any kind of eye procedure in the past or injury, any other eye disease, anything wrong with your eye, it's going to put you at risk for retinal detachment. Okay. Manifestations, you're going to see light flashes, you can see floaters. Once the detachment starts to happen, it's going to be painless, and then it can be described as a curtain. It just goes black, either right in the middle, it just depends on where the detachment is, or you can have peripheral vision loss. So it's like a curtain, it's like a blackout. Diagnostics, we're going to do visual acuity measurements as always. We're going to use an ophthalmoscope or slit lamp to take a look inside the eye. And then we can also do ultrasound for confirmation. Okay, so there's also a couple different things that can be done to treat retinal detachment. So we can do surgical therapy. So this is where they use our own body's way of so what it does is, okay, so laser photocoagulation. They put the laser in and they're intentionally causing inflammation, and that inflammation kind of seals that hole, makes a scar, and that's what potentially they're pretty much using that to seal up the hole that caused the retina detachment. Cryopexy is the same thing, but they're using they're freezing with cold. Scleral buckling is when they kind of wrap a belt around there to hold pressure around the globe where the hole is. Okay, so this is what you need to pay attention to. Intraocular procedure, an example of that would be a pneumatic retinopexy. And this is when they inject gas, that's this picture here. So they're injecting a gas bubble, and that little bubble is positioned just right to float where the tear is. And that little bubble acts as kind of pressure to, hold it in place while the body can close it up and fix itself. Another thing they can do is a vitrectomy, where they remove that vitreous humor, okay, and they replace it with something else. And again, when they replace it with this other jelly, it kind of pushes up on that hole. So what I want you to remember is the postoperative considerations. So just this little bubble that they're placing there, you don't want it to move during the healing process. So they're going to be on bed rest and strict activity. So they shouldn't be doing cartwheels. They shouldn't be walking around the, the block. They should be in bed or on the couch, not doing anything. They should protect the eye that had the procedure. They might have some discomfort, so they might have some pain meds. They might have some antibiotics, corticosteroids, mydriatics. And then you want to educate them to really relax the eye. You don't want rapid eye movements, and they definitely need to protect their eye. Okay, moving on to age-related macular degeneration, or AMD. This is the most common cause of irreversible central vision loss in people over 60 in this country. So if you look at this picture here, the one on the left is normal. The one on the right is how somebody with this disease sees. So central loss of vision, that big black spot in the middle. So etiology, retinal aging, and genetics. Risk factors would be family history, if you have light colored eyes, if you have high C-reactive protein levels, if you smoke, and if you have hypertension. Okay, so clinical manifestations for this one: acute vision loss, blurred or darkened vision, blind spots, and some visual distortion. Okay, so let's look at what the macula is anyway. So the macula here, okay, it's in this picture. It's this little spot about 5 millimeters across on the back of the eye, on the retina. Okay, so it sits on the retina, it sits right here, and it is responsible for our central vision and most of our color vision. So it's a really important part of our eye. Diagnostic studies, again, visual acuity via Snellen chart, that's our baseline. Again, the ophthalmoscope and the Amsler grid test, which you'll see next. So this is an Amsler grid test. On the left, the grid is printed on a piece of paper or a cardboard, and it's given to the patient with a marker, and then they transfer over to the right what they see. So the picture on the right is an example of what they might see, and that's how the doctor can kind of determine the extent of the AMD. So there's two forms of age-related macular degeneration. We have the dry and the wet, the non-exudative, and then the exudative. So the dry is much more common, and it's slow, progressive, and painless. And this is actually atrophy of the cells in the macula. The wet exudative is more severe, so this is the one we definitely don't want, and the dry can actually turn into the wet one. So this is when abnormal blood vessels develop in or near the macula. Okay, and that's going to cause more problems. It's going to be rapid onset of vision loss, and the patient can potentially go blind. So for these patients, they can get these injections into the eyeball, okay, every 4 to 6 weeks into the vitreous cavity, and this is going to stop those vessels from forming, and hopefully it'll slow the progression. So these are the medications here, okay. So photodynamic therapy uses a dye, which means the patient's going to be injected with a dye, and then after that, a laser is used to activate the dye in the eye. So it's important that these patients are instructed not to go out into direct sunlight or intense light for 5 days. And the reason for that is the sunlight can actually activate whatever's left that hasn't been excreted by the body of the dye, and that process can start happening. So it would be like if we were shining a laser in. So we want to keep them in the dark for a while. Nutrition, here's the nutrition. So this is nutrition for your eyeballs. So this is vitamin C and E, beta carotene, zinc, and lutein. Examples of lutein would be kale and spinach, and then also fatty fish. Okay, and then of course we want patients to stop smoking because smoking constricts blood vessels, and we don't want that. Next up is glaucoma. So what is glaucoma? So glaucoma is increased intraocular pressure, and all of that pressure inside the eyeball causes the cells on the optic nerve to atrophy or die. And when that happens, we begin to have peripheral visual field loss. So the outside of our visual field in our peripherals begins to slowly diminish, and eventually these patients will have tunnel vision. So why does this happen? So glaucoma is the second leading cause of permanent blindness in the United States. And it is more prevalent as we age, as we get older. And we really want to try to catch it early so we can prevent blindness. So what is happening here? So aqueous production and aqueous reabsorption must be balanced to maintain intraocular pressure. So that means that that aqueous fluid that we have inside of our eye, it's constantly at a balance. We lose some, we gain some, we lose some, we gain some, but there's always a balance. It's when that balance becomes too much, there's too much pressure, that's when we start having these issues. So the outflow, okay, where the reabsorption occurs in our body, occurs at the angle where the iris meets the cornea. So let's see where that is. It's where the iris meets the cornea, right here where I'm circling. That's what we're calling the angle, and that's part of the name on the next slide. So that's the angle. So when the inflow is more than the outflow, meaning that there is more aqueous fluid coming in than going out, that's going to lead to increased intraocular pressure. This increased ocular pressure is going to result in permanent loss of vision, which is what we're going to try to prevent. All right, so let's talk about it. There are two types of glaucoma. The first one is primary open angle, or POAG, or angle closure glaucoma, ACG. So let's talk about the primary one. So we're looking again at the drainage canals here, right at these little angles, okay? Right here. There's one at the top and one at the bottom. And again, that allows the outflow of that aqueous fluid to maintain balance. So with primary open angle glaucoma, the outflow is decreased, okay? Those drainage channels are clogged, but there is still some outflow. So the pressure is high in the eye, but there's still, you know, some drainage that's being allowed. Okay, so that is open angle glaucoma. In angle closure glaucoma, this is when those angles where the iris meets the cornea, those drainage canals are closed. Okay, that's the difference. So that means that there is no outflow of that drainage. So that pressure in the eyeball is just going to keep building up. And this is considered a medical emergency. Okay, so angle closure glaucoma is considered an emergency. So let's look at the clinical manifestations of both these types. So POAG is initially asymptomatic. It's going to happen over time, slowly, without symptoms of pain or pressure. The patient usually does not notice the gradual visual field loss until it's severely compromised. Okay, so this is happening over time. As a result, eventually, if the patient is untreated, then their vision will result in tunnel vision. So it looks like they're, you know, looking in a tunnel. All of the peripheral vision will be dark and black. With ACG, which is acute, so that means it's going to be sudden pain in the eye, around the eye. It can cause nausea, vomiting. They can experience colored halos, definitely blurred vision, and some ocular redness. Again, that is the medical emergency type of glaucoma. Okay, so here we have this box of the normal IOP, intraocular pressure, 10 to 21. So remember that number because that is normal, and as a nurse you need to understand when things are abnormal. So how are these patients diagnosed with glaucoma? We are going to do a tonometry study. That's where, if you've ever had your eyes checked, where they blow that little burst of air in your eye, or they even have like a little, I don't know what you call it, a little thing that kind of touches your eye to determine the pressure. So to be diagnosed for POAG, it's going to have an intraocular pressure of 22 to 32, and then acute ACG is going to be IOP of greater than 50. Okay, the patient will also have a visual acuity test, slit lamp microscopy right here where they shine the light in. And if they use an ophthalmoscope, then they'll see optic disc cupping. Okay, so that's something that they would see with glaucoma. how are we going to treat this? So the main goal is to lower the intraocular pressure. Okay, so that will in turn prevent that nerve damage, will prevent vision loss. So the approaches are a little bit different depending if it's POAG or ACG. So for POAG, these are some medications, okay, and these are in the form of eye drops, okay. Some of them may sound familiar because there's also oral medications that are given for other diseases also, same type of medication. There's also surgery, a surgical approach where they can try to open up the little channels, maybe putting in a tube or some kind of implant, something like that. But just remember that this problem is going to be lifelong. There is no cure. Okay, even with surgery, there's still a potential for the intraocular pressure to build up. So here, a teaching point for your patients, these medications help to control glaucoma, but they don't cure it. So this is going to be lifelong. For acute angle closure glaucoma or AACG, again, a medical emergency, okay, these are the medications of choice. And also there is an option for surgery. Again, this is going to be lifelong chronic problem to manage on an outpatient basis. We want to promote early detection and treatment. So when patients come in, you always want to do that visual acuity test and monitor for any vision changes. You want to educate them to report any vision changes early, whether it's photosensitivity, sensitive to light, or blurry vision, or if they see anything in their vision that's, not normally there, then they should definitely report it. So here are the recommended visual acuity tests, eye exams based on age. Okay, so if the patient is in the hospital, so this is acute care, we're going to be giving the medication to lower that IOP as prescribed by the physician or provider. If they have surgery, then we are going to give instructions. That's going to be our role, pre and post-op instructions. We always are going to encourage eye hygiene, so keep your eyes clean, don't cross-contaminate, don't touch dirty things and then your eyes. You always want to practice good hand hygiene. Signs and symptoms of infection, we know that. Don't increase intraocular pressure, so no bending, coughing, picking up heavy objects. Don't bear down during bowel movements. We need to really educate them on the medication regimen. So these patients are going to probably be prescribed several types of drops. Those drops need to be instilled separately with an interval of at least 15 minutes in between. Again, as I mentioned, don't focus on how many minutes in between. There just needs to be an interval so that each medication has time to be absorbed. Also, because of these medications can potentially be absorbed systemically through the little puncta in our eye where our tears drain into, we're also going to be educating the patient to avoid that by putting some pressure, and we'll see that on the next slide. Pain medication may be prescribed, and of course we want them to follow up with the provider once they leave the hospital. Ambulatory care. So this is when they're already at home. Okay, this is outpatient. It is a chronic condition, so they need to follow their medication regimen. They have to take those medications lifelong, and they need to follow up with their doctor. We want to give them accurate information about disease and treatment. So again, this is forever. You don't stop taking your meds. And then please review table 20.13 in your textbook, page 371. It gives a little bit more information on the anti-glaucoma drugs. All right, so gerontologic considerations, which are going to be most of the patients who have glaucoma in the first place. So consider systemic illnesses and medications. So people, as they age, are going to have or potentially have other comorbidities that we are treating with the similar type of medications. So if they're using these eye drops, then this can increase the effect of the therapy that they're already taking, or maybe it's even contraindicated. So we want to pay attention to that. We want to look at their medication record just to make sure that there aren't going to be any adverse reactions. So this list here These medications should have cautious use or may be contraindicated altogether. So if a patient has any heart condition, they should stay away from beta blockers, and so on. Okay, so as you can see, it's kind of generalized. Okay, it doesn't list the medication specifically. This is just a little overview. More importantly, you just need to understand that these medications, you need to check the patients more because there can be some contraindications. Okay, yes, you should be familiar that beta blockers, adrenergic blockers, hyperosmolar agents, all those things, yes, and which they pair into. That's all you need to know at this point. Patient education, occlude the puncta to limit systemic absorption of glaucoma medication. So the puncta is right here in the corner of our eye. Okay, right here. If you look in the mirror and you pull down your bottom lid, you can see the little drainage, the drainage channel there. So the idea is you instill the eye drops, they close their eyes, and then gently put a clean finger right over the puncta for 30 seconds to a minute, and that is good enough, okay? That will prevent that medication from being absorbed systemically into the body. Now we're moving on to intraocular inflammation and infection. So we talked about extraocular previously, so now we're talking about intraocular. So these are all the structures that are inside the eye, which can get inflamed and infected just like any other part of the body. So first up is uveitis. That includes the uveal tract, retina, vitreous body, and optic nerve. So all of those things can become inflamed for various different reasons. We have cytomegalovirus retinitis, or CMV. This is common in patients who are severely immunocompromised, such as a patient with AIDS. We have endophthalmitis, which is inflammation of the vitreous cavity. This one tends to be as a result of bacteria entering the eye from surgery, or like if the patient's having an eye injection and bacteria somehow just makes its way in there during that procedure. So all of these things, they're treated just dependent on what is causing it. So if it's a bacteria, we're going to treat it with antibiotics. Either it's going to be in the drop form, the ointment form, or in the intravenous form, systemic, just really depends. If it's from a virus, then we're going to treat the symptoms and possibly use antivirals if appropriate. Okay. So moving on to ocular tumors. So uveal melanoma, we are familiar with melanoma. We know that that cancer invades those melanocytes and mutates them, causing this cancerous growth. And this is cancer of the iris, choroid, or ciliary body, which you can see in the picture there. So similarly to just any skin cancer, melanoma, those at risk are going to be light-skinned people with light eye color, over the age of 60, and who have chronic UV exposure, aka people who spend a lot of time in the sun and they don't protect their eyes. Clinical manifestations are going to be really not much going on until the little tumors become significant. So it may be asymptomatic, or they may have actual loss of vision. It really depends on where the tumor is located in the eye. How big is it, and what damage it starts to cause. That's what the patient's going to experience as their manifestations. Diagnostic studies, so it's going to be ultrasound, MRI imaging to look for tumors, and then with any cancer, the definitive way to diagnose cancer is with a biopsy, is to get a piece of that tissue. So that's what's going to be done. They're going to biopsy those little tumors or tumor. With any cancer, the cure is to remove it if we can. So with this, enucleation might be appropriate. That's where the whole globe is removed, the whole eyeball. They may need radiation photocoagulation or eye wall resection. So they may just, cut a piece off and then try to repair it so that the patient can still keep their eye. So it just depends. Here's some pictures of what this may look like, uveal melanoma. Here we have enucleation. We just mentioned this. It's the removal of the globe or the eyeball. There are several different reasons why somebody might need or want to have their eye removed. If the patient is blind and the eye serves no purpose and maybe they were disfigured from trauma, something like that, then the eyeball might be removed. Maybe the patient has severe glaucoma and lots of pain, there's no way to reverse those effects, then the patient will have the eye removed. Infection, trauma, or cancer treatment, it just depends, but those are all reasons why they may need enucleation. So the surgery is going to sever the extraocular muscles, and so that means they're preserving the muscles. They're only taking out the globe, and that's so that they can hopefully in the future have an implant. So typically a clear conformer is placed. It's a plastic round shape to keep the eye in that shape, because if you don't, the eye will kind of collapse. Where the muscles are, where the globe usually sits, it will kind of collapse in on itself. So to prevent that, they insert a clear conformer. So post-operatively, very similar to any other surgery, you're going to assess for complications. You don't want excessive bleeding, swelling, pain. You don't want that, if they have an implant in, they don't want that to be displaced. And you want to, of course, monitor for fever, which can be an indication of infection. Education you're going to give to your patient is medication instructions, so how to instill the ointments or eye drops, and we talked about that. You never want the tip of the applicator to touch the eyeball, and that goes the same for the eye ointment or the eye drops. Wound cleansing, you're familiar with wound cleansing, and then how to insert the conformer. Losing an eyeball can be a serious thing. It can cause a lot of psychological changes, so we want to provide emotional support for both the patient and the family. Patient should come back within 6 weeks for a follow-up just to make sure everything is healing appropriately. There is a specialist who will fit them with a permanent prosthesis, and they will provide the education on that. And again, this is just another picture, and by definition, enucleation is the entire eye, including the globe, is removed, but the orbital contents are left in place. Orbital meaning like the muscles, everything surrounding the globe is left in place. Okay, and that concludes this chapter. The next few slides are just practice questions, so I will just flip through them so that you can see them.